For this air quality management lecture series. We have, started this lecture about 2 years back, and we are now today's is the 17th lecture. This lecture series being supported from Department of Civil Engineering, IIT Madras, and GCRF Clean Environment and Planetary Health in Asia, CEPHA network. Thanks to all my colleagues who are part of this CEPHA network for successful organizing this air quality management lecture series. So the one of the objective of the CEPHA network is to engage all the researchers, citizens, policymakers, stakeholders, industry, and the various members that are contributing to in addressing the environmental issues. Then we also look for identifying what works, what is the knowledge gaps, key challenges, barriers that enables in development of or prioritizing the solutions that can provide multiple benefits. We also look for strengthening the international cooperations, knowledge exchange, in addressing the environmental pollution and control issues. And the capacity building in one of the aspect, and that's where we air quality management lecture series helps to widen the participation across the sector, socio-economic groups. And of course, we also look for generating the resources, research income through new research grants. The overall goal of CEPHA network is to develop long-lasting partnership with our all colleagues and younger, community to address environmental, pollution issues in Asia. So these are our CEPHA network team members, which contributing to larger extent the success of this particular network. We also have collaborators, both India and outside, representing both academic research and also the other, active organizations. So CEPHA network basically addresses the 17 goals, which covers from no poverty to partnership and for the achieving the environmental management goals. So we were trying to look at it to the various aspects of environment and addressing the key challenges. We have initiated several activities. We have a successful in launching Prakriti as a newsletter. We have made a documentary film which talks about how to manage solid waste management, particularly for the school children. And we also conducted several workshops, events, competitions to the children's and the younger minds, professionals in addressing the various aspects of environmental management. We also organized several workshops in addressing the environmental issues. So air quality management lecture series is one of the first of its kind in India. As I told you, we started this in October 2020, and it provides an important forum for young researchers, scientists, engineers, educators to learn what is the latest advancement in air quality management, covering health risk, control technology, and various new research dimensions in the air pollution. So it also helps to explore the collaborative opportunities both for new professionals and also the experienced one. So as I told you, we started with the first lecture with Dr. B. Sengupta, the former member secretary of Central Pollution Control Board, very well-known, renowned, regulator in air quality management. And we have invited several experts who are very well known in the field of air quality management. And the last lecture was delivered by Professor Peter Boris. Again, he's also well known in air quality and health risk assessment. Now, coming to today's lecture, it's a great pleasure to welcome Professor Dr. Prabhakaran. He's a vice president, as a well-known researcher and policy maker in the health science associated with air pollution. He's also set up PHFI, Public Health Foundation of India, and a well-known research organization in addressing the air pollution and related health issues. So with this, I welcome you all to the lecture. Now I request Dr. Suvarna to introduce Dr. Prabhakaran. So I welcome you, Dr. Prabhakaran, and now Suvarna will introduce to the.
Good afternoon all. I am pleased to introduce Professor Dr. Prabhakaran, who is a cardiologist and epidemiologist by training. He is currently the Vice President, Research and Policy in Public Health Foundation of India and Executive Director of Center of Chronic Disease Control, New Delhi in India, as well as a professor in London School of Hygiene and Tropical Medicine, UK. He is also head of the Department of WHO Collaborating Center for Surveillance, Capacity Building, and Translational Research in Cardiometabolic Diseases, Center for Control of Chronic Condition at PHFN. In addition, he also holds different visiting positions in Canada. His area of research is to understand the causes of cardiovascular diseases among Indians and solution for CVDs. He has mentored over 50 postdoctoral and doctoral students so far. He has authored several chapters and research papers at national and international level, having a H index of 93. He listed as the topmost researcher in the medicine in India in terms of the publications for the year 2009-2014 by Scopus and Department of Science and Technology, Government of India. I welcome you, sir.
Yeah, I'll stop now, Dr. Prabhakaran, and on behalf of Air Quality Management Lecture Series Committee and CEPHA Network, we welcome you all. We welcome you, sir. So welcome all other participants to this lecture. I'll stop now for sharing my screen. Now I request Dr. Prabhakaran to share the screen.
Right. There's a lot of echoing. Is it there in your end? Dr. Nagira, is it there?
We will see that one because two of your mics are on. I will make one of them unmute. Okay.
My mics?
We are connected to one. We will unmute and so that it will echoing can be reduced. Okay, we'll do that.
Okay. Right. This is no. Still there is echoing because after I speak.
From us, it is very clear now.
Okay. Right. Thank you for inviting. Is it because I'm speaking from the airport? Should I take off the airport?
Yeah, maybe you can just check, sir. If it is possible, if it is okay, then you can do it. Hello. Okay, now I'll ask to unmute.
Right. So is it better? No, it's still echoing.
Okay. See, I think what is happening is we have connected with the two system. That's why it is echoing. So how do we? So you have shared with the other one. See that whether we have. Can we remove it? The other system which you have connected. Now let's. We will remove it one system which you connected. Let us see whether it should be okay. So Swaroop, can you unmute the other one?
Yes, sir.
Yeah. The one is sharing the screen. You unmute that.
Okay, is this better?
Yeah. You have one more system or some phone might have been connected. Can we?
No, I'm not connected to that system. I'm connected only to the link. I will disconnect everything and come back.
Okay. I mean.
Hello, sir.
Yeah. Swaroop, okay, one you can remove it. Yeah. Now it should be. You removed the other one which he has joined.
Am I okay now?
Yeah, you are okay, sir. Now you can just start the camera and you can just go ahead with that one. Yes, that's good now. Yeah, good.
Where do I share?
Maybe you can just go to the share. You already shared the screen. Maybe you can reduce it and you can stop. Click on your presentation.
Just open the presentation. I'm sorry about all this.
No problem. Yeah, this all.
Are you able to see my screen?
Yes, we are able to speak. Go to the. Yes, sir. We can. Yes. Yeah. Thank you. And please go ahead, sir.
Okay. Thank you very much. And I'm sorry for all this confusion. I originally started putting it on Safari and it was not working. Then I went to Google Chrome and it started working, but I think Safari got connected later on and that must have been the problem. So thank you for inviting me. It's an honor to be here and make this presentation. What I'm going to do is I've titled my talk as a 360 degrees view of air pollution and cardiovascular disease in India. So what I mean by this is I'm going to look at exposure assessment. What are the innovations in that exposure assessment? How do we assess health outcomes and how do we relate this, the exposure with health outcomes? And I'm going to use hypertension as an exemplar for cardiovascular disease. But in addition, also look at some of the capacity building activities as well as advocacy activities for air pollution. So I'll try and be brief and finish in 45 minutes or so, although I have an hour. So we need to look at multiple things when we talk about a 360-degree view, from the mechanistic pathways to building a movement against air pollution. So I'm going to talk about exposure assessment, as I said, outcome assessment, establishing the link, research and mitigation, and health sector capacity building, because as exposure scientists, you may be well aware of air pollution, but in the health sphere, not many people are aware of air pollution as a major determinant of health. They may be aware that it causes bronchial asthma, it increases asthma in children, but not many people are aware that it is more than asthma, causes multiple problems, including cardiovascular diseases. So let me start off with non-communicable diseases. According to the UN Declaration, non-communicable diseases are 5 major diseases. That includes cardiovascular disease, cancer, respiratory diseases, diabetes mellitus, mental health conditions, and they're bound by 5 main risk factors: tobacco, unhealthy diet, physical activity, alcohol, and air pollution. Just around 2 years back, it was called 4x4. That means mental health conditions was not there in this mix and air pollution was not there. The WHO used to have only 4 major diseases and 4 major risk factors. In addition, there are other chronic diseases such as cirrhosis, kidney disease, oral health, eye health, etc. But today my main focus is going to be on cardiovascular disease because it contributes to 50% of the chronic disease mortality worldwide. So 7 million people are exposed to air pollution, and both household and indoor air pollution. Among the 7 million deaths, 34%, a third of the deaths are due to ischemic heart disease or cardiovascular. And if you combine it with stroke, it becomes 54%. As I said, cardiovascular disease comprises of heart disease and stroke together, and that contributes to 54% of the total deaths worldwide. And as you can see here, over the years, air pollution is actually emerging as a major cause of death, both in females and males. And these are data from 2016, where you can see that amongst males, it was the number 2 cause of death. The first cause of death, of course, was smoking there. And amongst women, air pollution was the number 1 cause of death. We are all familiar with this figure. All parts of India exceed the WHO guidelines for annual exposure. I mean, this was before the last year when WHO changed its safe levels to less than 5 microgram. Even with 10 microgram, you can see 99% of the districts are above the WHO annual exposure guidelines. The Indian government has a little liberal guidelines in terms of less than 40, and even if you use that criteria, 60% are above national ambient air quality standards. So these are data from 2017. These are model data published by Dr. Kalpana Balakrishnan from the city where you live. She's from Ramachandra, and this was published in collaboration with the Public Health Foundation of India. And this gave us data suggesting that the annual population weighted mean exposure to ambient 2.5 was 90. That is twice the recommended value for the national air quality standards, and almost 9 times, now it would be 18 times the value which has been put out by the WHO. The Indo-Gangetic plain has the highest exposure, and the proportion of people using solid fuels in India is around 50%, but it exceeds 70% in several of these states which are considered poor. They estimated that close to 1.24 million deaths, that is 1 in 8 attributable deaths in 1 in 8 deaths in India, are attributable to air pollution, and nearly 60% of it is due to ambient air pollution, and 40% because of household air pollution. They said more than 50% of the deaths due to air pollution are premature, by which we mean that majority of these deaths occur before the age of 70 years. And they estimated that on an average, there is a loss of 1.7 years of lives in terms of life expectancy. So that's the problem of air pollution in terms of health. Now, how does air pollution increase the risk for cardiovascular diseases? By cardiovascular diseases, I mean heart attacks, stroke, heart failure, gangrene, angina, and several others. So the first thing is PM 2.5, as you all know, is a very small particle. It's a 2.5 micrometer particle, and it can actually, when we breathe in, it goes into the alveolus, which is the smallest unit in the lung, and it crosses what we call as the alveolar blood barrier and enters the blood. When it enters the blood, on the blood vessels, there are cells that line the blood vessels, which is called the endothelium, and this endothelium is a very important organ. It helps in the constriction and dilatation of the blood vessels as the blood flow, and it regulates the blood flow. Because it goes and destroys the endothelium or causes endothelial dysfunction, there is a stiffening of the blood vessels, which results in an increased blood pressure. It also causes inflammation by depositing in the fat cells in the abdomen. It oxidizes the lipids of the fat cells and results in secreting several inflammatory hormones. It increases blood pressure directly, and it can cause abnormalities of the heart rhythms. All of these can lead to what we call as metabolic abnormalities, that the blood sugar is high, there is bad blood fats or lipids, high cholesterol, high LDL cholesterol, all of which leads to deposition of waxy substance in the arteries, resulting in atherosclerosis, resulting in high blood pressure, resulting in irregularities of the heartbeat, and decreased function of the left ventricle. This ultimately results in ischemic heart disease, peripheral vascular disease, heart failure, and arrhythmias that can result in sudden death. So what is the current status in terms of air pollution, and what is the solution that we have? Most data linking air pollution to cardiovascular disease come from high-income countries. The exposure assessment has been done in India at a coastal level. Only now we have started doing it at a very fine level of 1 kilometer into 1 kilometer radius. There was past data from India on the link with cardiovascular disease, and most of them were model data, and they were largely cross-sectional. So I'm going to use the example of hypertension, and I'm going to use two big projects that we did. One is called CARS, which is a longitudinal cohort that we established in Delhi and Chennai of adults over the age of 20 years. And we have been following these people over the last 10 years. And then I'll provide a little bit of detail about this longitudinal study. And the second is GEOHealth. So we are a GEOHealth hub funded by NIH. And there are 7 GEOHealth hubs across the world which work in the area of environmental pollution. So I'm going to use these two as the vehicles to address this question. In a simplistic scheme, what happens is we are trying to link exposure to an outcome. It should be O there. Sorry about the mistake. It's E, which is related to O. Now that's the simplest way. We can say that, okay, there is a certain exposure and this exposure causes outcome. Along the way come what are called as confounders and effect modifiers and other variables which influence that. So we have to adjust statistically for that to robustly show that a particular exposure is related to outcome. And again, I'm going to use CARS and GEOHealth here. Now, what is CARS? It's a population-based sample of 19,000 plus adults who have been followed up for over 8+ years. It is representative of the megacities of Delhi and Chennai. It has a carefully phenotyped and geocoded study population, and we have close to 360,000 aliquots of sera, plasma, buffy coat, and urine, and we have DNA subsamples from them. Now, this is how we have conducted the study. We recruited these people in the year 2010, 2011, and collected a whole bunch of data, which included questionnaire data, their anthropometric data, their blood pressure, the body weight, then biological samples that included blood, urine, and saliva. Every alternate year, we follow them up with what we call this pen and pencil follow-up in terms of looking at, did they get admitted to a hospital? Did they have a heart attack? Was there any other illness? Or did somebody die during the interim? So every alternate year, we go back and collect blood samples from them. In 2016, we added another cohort to make this a dynamic and a powerful cohort. And I'm very pleased to say that the annual follow-up rate, we have at least one follow-up in 85% of the people, but 3 follow-ups in 65% of the people, a very powerful cohort in terms of studying several outcomes. The GeoHealth program, on the contrary, the main objectives of that was to create a robust exposure assessment of PM2.5 at finer resolution, link exposure to cardiovascular risk factors and outcomes, and also have capacity building in the science of air pollution. So it's a fully integrated research and training program on air pollution and cardiometabolic diseases, policy relevance to improve health outcomes of Indians. So in GeoHealth program, the main objective was to link PM2.5 levels to incident cardiovascular risk factors and outcomes in Delhi and Chennai. So this is the map of Delhi. The total area of Delhi is around 1,635 square kilometers. So we have, 1,484 square kilometers, and we have classified this into multiple grids. And you can see there are a total of 1,635 grids of 1 kilometer into 1 kilometer resolution. And we collected data over a 7-year period. We collected data of every day for 7 years from the year 2010 to 2016, which means 2,557 days. And we had close to 4.2 million observations. And what are the data that we collected? We collected daily data on average of PM2.5 and PM10 from the 25 stations in Delhi. We collected satellite data and obtained the aerosol optical depth from which we estimated the PM2.5 levels. We also obtained the vegetation index, the ultraviolet emissions, and the active fires. From the emission inventories from the polluting industries which are located around Delhi, we obtained grid level area emissions for PM2.5. And we also obtained weather data because it's very important to have weather data The high temperature can reduce air pollution, humidity. If there's rain, it can wash away the wind speed. We obtained data on precipitation, cloud cover, evaporation, soil temperature. And we also needed to adjust for land use. In fact, if there's a lot of greenery, air pollution levels may be lower. And close to the highways and roads, air pollution levels are higher. So we obtained a complete map of Delhi with land use patterns. Now we put all this together in a machine learning model called ensemble modeling. So you can see here we are monitoring data, aerosol optical depth, and land use variables. And we use a chemical transport model called Geoschem and adjusted for meteorological variables and obtained PM 2.5 levels over a 7-year period. And as you can see, the color changes depending on the level of PM 2.5. The darker the color, higher the level of PM 2.5. And now you can see as we approach the winter months, it becomes darker and darker. But what you can see here is between 2010 and 2016, it starts appearing to be darker much earlier in the month of October itself and stays on for much longer till the month of February. That means the pollution level increased substantially between the years 2010 and 2016. The other thing that we looked at was what is the level of physical activity in our cohort. Now here is a cohort which has low physical activity. What do we mean by low physical activity? We mean that we calculated the median level of physical activity in our population, and anything lower than that median we said is slow. But what did this low physical activity connote? It also said that people who have low physical activity have high blood pressure. But when you pictorially look at it, what we see here is there's hardly any greenery, no parks, highly clustered houses, very close to a highway, all recipe for high levels of air pollution. Now this is pictorially you're saying, but you need to empirically show this indeed is the case. So we looked at what happens whenever there is a high traffic density. High traffic density was associated with high blood pressure in our cohort. The larger the dots, higher the blood pressure. It's not hypertension, but it's higher than the cohort mean. So where there is high levels of traffic density, people living in around that area had high levels of blood pressure, and people who are living farther away had lower levels of blood pressure. One might say these are people with different socioeconomic status, but even after adjustment for socioeconomic status, this increase in blood pressure persisted. Now we looked at a comparison and said, okay, there is this given individual. What happens to his or her blood pressure in relation to the air pollution level over the last 1 week, over the last 1 day, over the last 1 month, 3 months, and 1 year. And as you can see here, the systolic blood pressure is related to PM 2.5 levels, irrespective of the time period from which we are looking at the blood pressure, whether it be it a day or be it a year, the level of blood pressure is higher by 2 to 4 millimeters in relation to an increase in PM 2.5 by an interquartile range. The good thing for us in terms of calculation is on an average, it was around 100. So if from 75, it increased to 100, the blood pressure levels increased by 2 to 4 millimeters of mercury. Diastolic, it was not very clear, but it still increased by around 1 millimeter of mercury. So clearly there is a link with blood pressure. So you might argue that so what if my blood pressure is 120 and it goes to 122, it is still not hypertension. So that's true at an individual level. One might also argue that, if I get it down to less than 25, if I get it down to less than WHO standards, it will reduce by 12 millimeters. Now, even that doesn't, you can say that my blood pressure is usually 110. Because of air pollution has gone up by 12 millimeters. How does it make a difference? It's still within normal limits. But when you look at it at a population level, it makes a big change. Before I come to that, let me show you something interesting here, that the body weight actually has an interaction. If you're obese, if you have a pot belly or your what we call a central adiposity, the blood pressure levels are higher. And the second thing that we noted was that if you're farther away from a green space, the chances of having blood pressure, higher hypertension was higher. So what we did was, in summary, we looked at around 3,200 plus individuals in 2,200 plus households with 3 BP measurement over 7 years. Long and short-term exposure to increased particulate matter concentrations was associated with increased blood pressure and risk of developing hypertension in urban India. For every 25 microgram per cubic meter of PM 2.5, the blood pressure increased by 3.5 to 5 millimeters depending on the BMI or body mass index, or obesity. Achieving national ambient air quality standards can potentially decrease prevalence of hypertension by 15% in urban Delhi. So why does this happen? Because it's a normal distribution. The blood pressure is a normal distribution. So once you shift the curve, you reduce the population level blood pressure by 3 or 4 millimeters, the whole curve shifts to the left. That means the number of people living with hypertension also decreases, and so there is a decrease by 15%. So this is what we call as treating sick populations by non-personal policy interventions, and can have major benefits. So the average annual PM 2.5 is 100. So you decrease, the current value is say 125, and you decrease by 25 and get it to 100. The percentage decrease in prevalence of hypertension is 5.3%. If you decrease by 50 and get it to 75, you would get a 10% decrease. But if you get it to the national standards, you would get a decline up to 15%. So the prevalence of hypertension comes down by 15%. This is what I said, that the blood pressure distribution is what we call as a bell-shaped curve or a normal distribution. So let us say this blood pressure is currently here. You reduce it by 2 millimeters, 3 millimeters, and 5 millimeters. When you reduce it by 5 millimeters, you can see the number of people with hypertension were all here have actually come here. So there is a smaller group of people with hypertension. And it translates to higher reductions in stroke, coronary artery disease, and mortality. Just even a 2 millimeter reduction in blood pressure in the population can decrease cardiovascular disease mortality by 3%. And if you go to 5 millimeters reduction, you can decrease the blood pressure by, you can decrease the mortality by 7%. So that's the power of intervening. So air pollution is called a social determinant of health. And so you intervene and reduce air pollution, you can decrease blood pressure. So this is again an analysis to show it's this similar occurrence with diabetes. This is under has been accepted for publication and is under publication, which again shows a similar phenomenon with diabetes. And this time we presented data from Chennai. So in fact, in Delhi, it was not that significant, but in Chennai, it was much more significant because Chennai has a lower level of air pollution. So what happens with air pollution is your risk actually keeps on going up, and then it starts plateauing at a certain level. Delhi is at the plateau level, so any incremental change does not make that much of a difference. Again, these are data to show what happens with glycemic markers in Chennai and in Delhi, and what are the other factors that influence. I'm not going to get into the details of all that. The next thing that we would want to know is it only PM 2.5, or there are other things such as black carbon and heavy metals? And so we did a personal exposure monitoring of 100 adults belonging to various age and socioeconomic groups residing in Delhi. So we gave them a personal air pollution monitor. We gave them a GPS-enabled triaxial accelerometer, which is put into a bag, and we obtained data of PM 2.5 also because they had a GPS and an accelerometer. We got the level of physical activity and also where they were going and coming over a 24-hour period. And so you can actually map out what they did in those 24 hours, and you can see where most of the PM 2.5 levels are very high. One is the transport level when they're coming back from the office, and they're at home, indoor pollution is high, and while sleeping also is a little high. So we can actually map out at what point of time so that you can actually control some of these and have some interventions in terms of reducing it. The other thing we noted was that even within a very small area, socioeconomic status matter because indoor air pollution is very high in the poorer population. In slums, PM 2.5 level was high within a proximal, within 400 meters distance, you could make out that people who are living in middle class localities or higher socioeconomic levels had lower PM 2.5 exposure. There's also a difference in a given family between husband and wife. You can see within a 24-hour period, this wife was exposed because of high levels of indoor air pollution, which comes from cooking. So this has been shown. I'm not going to talk about this. Then we also looked at, does it alter the genes? Does it cause any altered DNA methylation? We are doing that analysis. The results will come soon. So we're doing genome-wide analysis to see, are there any DNA methylation, altered DNA methylation patterns because of air pollution in a case-controlled design. And there are several other analyses that we are doing. We're looking at vitamin D and incident diabetes, cardiovascular events and mortality, PM 2.5 in relation to socioeconomic status, in relation to lipid markers, and in relation to obesity. So this is the thing about air pollution and obesity. And we have clearly for the first time in India demonstrated in a longitudinal study, because many of the studies that you would have known are cross-sectional in design. The problem in cross-sectional design is you're collecting the outcome as well as the exposure data at the same time. You don't know who died because of this, because they're not there in that equation. You don't know people who might have migrated. So there are many limitations to that. And longitudinal design is the best design because you're prospectively looking at people and seeing what happens to them when you give them an exposure. Now I'm going to come to some of the advocacy activities and the intervention activities. We all know that health sector plays a key role as a contributor and mitigator of environmental health. So we thought we should build capacity for research, communications, and advocacy in air pollution. So we created what is called as a health platform from the Center for Environmental Health to foster health sector leadership on environmental exposures, expanding the evidence base on air pollution exposures in tier 2 cities, advocating for effective implementation of air pollution policies and media sensitization. So we basically wanted to build capacity of the health sector and engage with them. Also, in addition, do air pollution monitoring, policy and advocacy, understand knowledge, attitude and practice of health practitioners towards health effects of air pollution in Indian cities, and a roadmap to achieve how to achieve national ambient air quality standards. So this platform has over 7,300 healthcare institutions in India, and we periodically engage with them. One of the ideas was there are 94 cities which do not have monitors, and whether we could use low-cost monitors and obtain PM2.5 in relation to this hospitals or institutions, and also provide some advocacy and health promotion messages in the waiting room of the patients. We also did a doctor study to look at the understanding and knowledge and awareness of doctors about health impacts of air pollution. The future, we would like to do a nationwide expansion. We have been funded for that. So we are going to do daily 1 kilometer and 1 kilometer prediction between 2008 to 2020, which will cover both rural and urban areas. And we are looking at health association studies to existing cohorts of maternal and child health, cardiovascular health, pulmonary health, diabetes and metabolic health, cognitive function, and several intervention studies. So this is about knowledge that we have acquired, but we need to do something to reduce air pollution, because just knowing is not enough and we need to intervene. And how do we do that? So one of these studies, which has been funded recently by ICMR and NIH, is to look at the effectiveness of indoor air purifiers on heart failure outcomes. We call this the PURI heart failure trial. So we are using a locally developed, I believe the people who developed this technology are from IIT Chennai. I can't recall exactly whether they're from, but I believe they're from IIT Chennai. They've developed patented technology that combines a HEPA filter and a novel effective granular adsorbent particle arrestor to reduce indoor air pollution. The HEPA filter removes all particulate matter up to 0.3 micrometer in aerodynamic diameter, and the dual stratified e-GAPA filter removes other pollutants such as sulfur, nitrous oxide, carbon oxide, volatile organic compounds, allergens, and mold. At 1 hour, this air purifier decreased PM2.5 concentration by 63%, and by 6 hours by almost 90%. So it has been tested, and the result shows high efficacy in PM2.5. So it monitors PM2.5 at real time at 1 minute resolution. Then there is an external Internet of Things platform for instantaneously transferring data on the secure cloud. It's blinded to the participants in order to not bias participant behavior and maintain blinding. And these data are used to monitor adherence and usage of air purifiers in real time. So we did a pilot study, and it showed that there was a substantial reduction in PM2.5 in the city of Delhi. We did in 20-25 households and clearly showed that it decreases. Now what we are doing is we are going to recruit 600 patients with heart failure, 200 each in Delhi, Chennai and Trivandrum. They will be randomly allocated to a HEPA filter and a sham filter, and we are looking at heart outcomes. Within a year, is there a reduction in death, myocardial infarction and stroke in people who used a HEPA filter? That reason why this is a very powerful study is there is close to 30 to 40% death or stroke in people with heart failure. And so we think it's a very powerful study to show if there's going to be a decline. The next thing that we are working on is to look at the role of environment, air pollution, and food systems and climate change, because this intersects in terms of fruit and vegetable intake and the environment. As you all know, fruit and vegetable intake is very important in the prevention of cardiovascular disease, but unfortunately, the WHO recommendation of 5 servings every day of fruits and vegetables is not followed in India because of cost and a variety of reasons. So we also looked at some systematic reviews and saw that wherever fruits are grown in water depleted areas like in South India, particularly in Tamil Nadu, there is a huge amount of water depletion. Not only is the yield low, but the beta carotene levels, which is a protective antioxidant in fruits, is low. And this just shows the complexity of increasing fruit and vegetable intake. And so climate change and air pollution and water quality plays a big role. And everything is interlinked. We are living in an interlinked world, because industrial scale livestock breeding can result in obesity, cardiovascular disease, and cancer. Climate change can result in increased methane and deforestation. There is food crisis because of grain diversion for industrial livestock breeding, and they also result in pandemics, like for example the present COVID-19 resulted from the jump of the coronavirus from an animal market into man. So clearly we are living in an interlinked world, and one of the things that we can mitigate is air pollution, and therefore we need to do that. The last is in healthcare. How is air pollution related to healthcare? And we think that telemedicine has a huge potential in reducing air pollution. So we created this PHFI telemedicine platform where we are using several digital health technologies which are developed in-house. Like we have an electronic clinical decision support system, a point of care device, an electronic AI-enabled ECG system, electronic stethoscope, and a high-definition camera. And then this is how the dashboard looks like. And there are several features that it gives out. Like for example, the doctor sitting remotely can have a detailed history, can also look at the findings which have been done by trained healthcare workers. It can give vitals with trends, provide lab results with trends, provide ECG readings, and provide electronic decision support system based advice for multiple diseases, provide a e-prescription and a history, and a markup for follow-up. And more importantly, it can actually, the doctor sitting remotely can hear the heart sound. So all the doctor does is ask the nurse or the healthcare worker to keep the stethoscope and can clearly hear the heart sound. So we're also looking at various modes of delivery. The conventional mode is for people to come to a designated center where the health worker collects the data and reaches out to the doctor. But here we have the health worker going to the house, because it can be actually put into these 2 small bags, which weighs no more than 4 kgs and can be easily carried. And you could conduct a telemedicine clinic at a house, or you can set it up using there is a mobile kiosk that we have developed. You can set it up anywhere at a railway station or a mall or a market, and people can consult their doctors. For remote areas, we could use vehicles in which this has been loaded and people can come in for consultation. So as I said, if we have to reduce cardiovascular disease in India, we have to address 4 important research questions. We need scientific credibility, and that's what we did with the air pollution and hypertension study, that we showed that there is evidence that air pollution really impacts hypertension. We need to look at financial feasibility. We're looking at the cost effectiveness of an air filter in the management of heart failure. We're looking at operational stability. This is the telemedicine project that I'm talking about. Can we make it sustainable? And whether people will accept such an intervention instead of actually having the doctor to do it. So just looking at the air pollution, you're addressing 4 different questions, and that's where the 360 degrees angle comes in. So for that, you require multidisciplinarity. That is why I'm talking to you. I mean, it's important for engineers and doctors to combine and work together. We need innovations that are disruptive. IITs are best known for their disruptive innovations. And if we work together, we can actually develop many of these innovations. And there is need for attention to policy and upstream determinants. So it's not only very important to do research, but we need to synthesize that information, disseminate that information, act on that information, scale it up, and make it a sustainable policy. So to make research effective, we need to fill critical gaps in knowledge, influence changes in policy that are informed by evidence from research, design and evaluate health programs for greater impact, and engage other stakeholders in the society. So we know that technologies are reductionist, but the solutions have to be holistic. So we need to combine multiple things to provide a good solution. So I just want to finish with this quote by the 10th century Persian philosopher who said there are no incurable diseases, it's only a lack of will. Thank you very much for listening to me.
Dr. Prabhakaran, thank you very much. It was a very wonderful talk, very useful. Let's, I'll just request the participants to use the chat box if you have any questions. Meantime, you can all start your cameras. We will have one picture with Dr. Prabhakaran, and then after that, we'll start discussing about questions. Okay, Swaroop, you have taken the picture?
Yes, sir. I have taken it.
Okay. One of the question I think Dr. Vera has, some measures will need to have political buy-in. So how do we plan to engage politicians on this kind of an issues?
Right. I mean, that's a very important question, basically because even 2-3 years back, I think the then environmental science and technology minister said there is no evidence air pollution is bad for health. So you have to generate that evidence and you have to synthesize that information in a simple language, create policy briefs, and actually make a presentation. I mean, there are several organizations which work with parliamentarians. First is to influence the doctor parliamentarians and talk to them. Then have a chat with the minister. So it requires a multi-pronged effort. It's not that we alone can do that. So we need to engage with several civil society organizations who are working in that area and engage with policymakers. So it's a multi-pronged approach. I mean, there's no simple answer to this question.
Okay, thank you. I have another question which follow up. You know that different age group and their exposure level and the time where they spent will all very complex. For example, if it is an highly polluted area and children are spending time and they spend about 20 years, is there any studies which looked into the duration of exposure, long-term exposure, short-term exposure, particularly the kind of a shock load that can trigger some of the health risk?
So the children's environmental health is an important area, and most of the studies are, not many studies are really available in that sense. There's one intervention study by Dr. Balakrishnan, Kalpana Balakrishnan, but that was specifically related to indoor air pollution and asthma, in which they showed that clean cook stove in the houses actually can reduce the number of asthmatic attacks. So similar things are, there's been a study from Mongolia, which again shows that pregnant mothers in whom filters were given had children who were born with a higher birth weight. As you all know, low birth weight is an important predictor of future heart disease and diabetes. And so they showed in middle class families, because air pollution levels in Ulaanbaatar is very high. So for pregnant women, they gave these air purifiers and showed that it works. So we require longitudinal studies. In fact, we have applied again for renewal of our GeoHealth grant, and one of the main aims is to bring together birth cohorts. So we have around 3 or 4 birth cohorts in this country where they have been followed up from birth till the age of one cohort has been followed up till the age of 15 years now, the other one till the age of 25 years, and so on. So we will come to know, because they have data at various points in time. We will retrospectively collect the data of air pollution in these places, and prospectively some activity levels data will be collected, and so we could actually model and see as to what happens. So you rightly pointed out the importance of what we call as a life course approach. it would be very difficult for one individual to do a life course approach. I mean, if you're a 30-year-old individual and you start a cohort of a birth cohort, which means by the time you're 80 years old, the population will reach only around 45, 50 years. So you want adult cohorts. So there are new mechanisms called interdigitating cohorts. Like I have an adult cohort, somebody's got a childhood cohort, somebody's got a elderly cohort. Can we bring all of that together and harmonize and collect data?
Thank you very much. There's one question. So this is also, in terms of the particulates measurement. Earlier we all talked about only the mass concentration. If particularly in the standards, they are all talking about what is the mass concentration for 24 hours or 8 hours. But now there are instruments which also measures number concentrations. So from the exposure point of view, do you think mass concentration or number concentration is relevant?
I mean, it's a good question. So far, what has happened is a large number of studies have used mass concentration. Number concentration is a new thing. We will have to look and see which one is better. But what we have shown is that the mass concentration, model mass concentration, there is a huge relationship. So there may be an incremental value, but first is let's attack the low-hanging fruit. And that's an important scientific question and for some of you to address. In the heart failure study, we are going to get both number concentration as well as mass concentration. So we'll have some data in 2 years' time.
This is one question, and can you discuss how the effect of change in lifestyle, particularly they're talking about usage of plastic, then less food quality can be eliminated with BP with PM 2.5. I mean, basically, how do we relate the lifestyle changes in terms of blood pressure and PM 2.5 concentration?
Right. It's a very important question. What we need to do is we need to consider lifestyle change in moderation. I mean, we cannot become martyrs. That's number one. Second is we cannot, as we are waiting for the government to intervene and reduce ambient air pollution, let's look at other lifestyle changes that we can do easily, which are low-hanging fruits. Don't take up smoking, because smoking is one of the biggest risks. And if you have a smoker in the house, encourage that person to stop smoking. It's easier said than done, but it's very important that we get people to stop smoking. B, reduce your salt consumption. So reduction of salt consumption doesn't mean that from today onwards, we're not going to put any salt in our food, but reduce the amount of salt consumption, reduce the consumption of foods that are very high in salt, like pickles, mixtures, some of the salt biscuits, chips, and so on. And these are unhealthy foods. So you reduce that, and so you can actually bring down your blood pressure by 2 to 3 millimeters in a 24-hour period. The third thing is be physically active. That is, exercise at least, if you're not obese or overweight, exercise at least for half an hour every day for 5 days a week. That's adequate to maintain the tone. Do around 5 minutes of stretching exercises, and that will actually tone your muscles, increase the glucose uptake, reduce insulin resistance. If you're overweight or obese, increase your physical activity to 1 hour along with some dietary changes. In terms of dietary changes, I think simple dietary changes, reduction of salt, reducing deep fried foods which are rich in trans fats, reducing eating out frequently or ordering food from others frequently, increasing the vegetable and fruit intake, and increasing the protein content of your food, be it by pulses for vegetarians and eggs and chicken, lean meat, or fish for non-vegetarians. That's the kind of advice that I would give. So, and if you're a yoga practitioner or you can manage to do yoga, I think that's a good enough lifestyle to get many of the cardiovascular risk factors to a lower level. But be an advocate with the government, be an advocate with policymakers to reduce environmental pollutants. And the biggest one right now is air pollution. Plastics, of course, they are doing something. It may take some time.
Yeah, thank you very much. There is another question, since we have also started looking into. This is a question from my student. We try to look at, is there any correlation between air and noise, because both coming for originating from the same source. Are there any studies on antagonistic and synergetic health effects of air and noise pollution on sensitive population?
So I showed that diagram, I showed that slide in which we are showing high levels of air pollution, high levels of higher blood pressure amongst those who are exposed to high traffic density and and people who are living very close to roads. So it's a good question whether it is because of air pollution or is it because of noise pollution, and the recent thing about light pollution also, whether we are exposed to light and because of exposure to light, your diurnal variation goes away, and because of that, you have non-dipper phenomenon amongst people with hypertension. So these are all interesting questions. I would say it's like climbing a mountain, and we are somewhere in the middle. We have not reached the peak. So this is another area of research which we have actually applied for that grant and we are working on. If we get that grant, we'll answer that question for you.
Sure. Yeah, actually, when we're going to interact with you, so we have started doing this measurements in different locations in Chennai. We'll happy to share with you. So there's another question on air pollution levels high in developed countries like US, also resulting in more cardiovascular diseases there. Or is this a problem confined to developing countries like India? That's the question.
Right. So one of the myths that we have is that cardiovascular diseases, be it hypertension or diabetes, is unifactorial in cause. So it is not. It is multifactorial. If you look at air pollution in the US, they get worked up if their PM 2.5 on a day goes to 25. In California, you have these forest fires in summer, and they have PM 2.5s in LA or in San Francisco going up to 20, and they really sweat it out. Unlike in Delhi, for example, in winter for days on end, we would have between 200 and 300. We don't think about it much. So then you might ask the question, why is that low air pollution in US and cardiovascular disease is not high? The fact is, cardiovascular disease was very high in the United States in the 1960s and 70s. And at that time, actually, the air pollution levels were higher there. That's one. The petrol, gasoline as they call, was very high in lead content. In fact, de-leading of petrol came in the 80s, I think. So that's one of the environmental thing that they have actually reduced. But also their dietary practices. They eat meat every day, which is high in fat. All the current theories suggest that it's not the fat intake, but it's actually the carbohydrate intake. But they eat, their total calorie consumption went up rapidly in the 60s from the 40s during the Second World War because of lack of food. And then suddenly the economy boomed around the 50s, and their calorie intake on an average every day increased by 400. 400 calorie increase is huge at a population level. So that's one of the important reasons. The food was very high in cholesterol, and smoking was very high at the time. And after the smoking in men started declining, the smoking amongst women increased. Physical activity reduced. Obesity levels are the highest. There are 2/3 of the people who are either overweight or obese. In India, this was in 2012. We don't know the exact data now, but in 2012, in India, overweight and obesity was only 12%. And then diabetes between US and India were similar. So there are other reasons why we have high propensity to diabetes other than obesity. We have what is called a central adiposity, where we have more fat deposited around the abdominal wall. And those fat are metabolically active because of the influence of liver and pancreas. There is increased glucose output from the liver amongst Indians. We have had frequent liver infections because of hepatitis and others. So clearly, it's much more complex than attributing it to a single risk factor. So you will have to look at ethnicity-related factors or country-related factors, which may be different. Like India and China are countries which are very close to each other. But when you go to China, the major cause of death is stroke. And in India, the major cause of death is heart attack. Why is there such a difference? Is it genetic? Is it environmental? These are interesting questions that we should look at and answer.
Okay. Yeah, maybe this will be the last question. Are there any data-based evidence to show that some population is more impacted by air pollution in Delhi compared to mid or higher income societies?
Preliminary data suggests that poorer socioeconomic status people have higher exposure to air pollution. Multiple reasons, though the ambient air pollution is likely to remain the same. they are living in single room tenement, single room households, where the cooking happens in that one room itself. Cooking, high temperature cooking can actually generate temporarily PM 2.5 levels to of thousands. So that's one of the things that can happen. Second is even doing simple puja also can have briefly a high level of PM 2.5. So there are, if you're living in a one room house and you're indulging in multiple activities, and if there's a smoker in the house, secondhand smoking can increase your PM 2.5. So there is a important socioeconomic thing, that is poorer people are exposed to PM 2.5, even though the ambient air pollution may be similar across the societies. And then the second thing is people who can afford have started using air purifiers, at least when they are in the rooms, and when they are at home, the PM 2.5 levels are lower.
Thank you very much for the wonderful talk, and thank you. Actually, the technology was developed, from our research group, and now we have an improved version. Maybe we are happy to, associate with you. Please let us know in the other, in your studies. We have come out with a little more improved version of that.
Yeah.
So now, I'll request Dr. Madhusudan to summarize the talk. And thank you very much, Dr. Prabhakaran.
Good evening and good morning to everyone. It is definitely an Herculean task to sum up this wonderful lecture. However, I will try to do my best. Thank you, Dr. Prabhakaran, for enlightening us the air quality and health impacts, particularly the cardiovascular disease and hypertension associated with ambient air quality. We appreciate you, the studies conducted and how it is interpreted in an engineering way by a doctor. Being a doctor, the outcome and how it is represented in terms of health viewpoint was quite appreciable, sir. The GeoHealth program covering 7 years of study, linking with the findings as a social determinant for health was quite interesting. The influence of inhaling PM 2.5 and how the standards or value affecting largely the population was quite interesting. The outcome at Delhi and Chennai studies definitely will help the policymakers, since WHO has also come out with new standards, and Government of India is looking for the standards to be revised. Definitely the study will help the policymakers to look into the new standards. He further discussed about the strengthening the capacity of research community and advocating the air pollution studies, the effectiveness of certain advanced technologies, and how the results related to heart failure was further discussed. The biomagnification, the effect of air pollutants in consumption of vegetables and fruits was also discussed in details. He concluded the lecture how these findings can transform and help the common man, like having the telemedicines, and he explained the working of such centers and how it will help the poor people in the country. He stressed the need of the research activity to be combined with academicians and the doctors and the research groups. The question answer session was excellent, and we could get answers which we were looking for, sir. He emphasized the need of self-help, that is keeping the healthy lifestyle to help the community and keep everyone healthy. Once again, I thank you, sir, for the wonderful discussion, and the question answers were quite interesting and quite thought-provoking. And on behalf of the CEPHA network, we thank all the participants who joined today's Air Quality Monthly Lecture Series 17, our colleagues, the regulatory agencies, the people from State Pollution Control Board, the senior professors from different IITs, the students, and also our friends. We thank all. The thanks are also due to our team, that is Dr. Suvarna and Swaroop Das. We thank Professor Shivanagendra for all the guidance and support for completing the Air Quality Monitoring Lecture Series 17th edition. We definitely look forward for the 18th edition next month, and we definitely will announce the lecture in advance. All the previous lecture series, the activities of CEPHA, one can browse through cepa.in. We welcome everyone to our website for for your suggestions and also the criticism. Thank you, everyone.
Dr. Prabhakaran, thank you very much. Please go ahead, sir.
No, thank you very much. I just wanted to invite your students and who are the participants for a program in the evening,
Sure.
where we've got international leaders speaking on how to write a paper. When
Sure.
writing a paper.
Thank you.
So it starts at 6:30. I've sent the link to Dr. Nagendra.
Yeah, we're going to share that one, sir.
Okay, right. Thank you.
Thank you very much, and so nice of you. And yeah, we look forward to associate more and more research in air pollution and health risk. Thank you very much, sir.
Thank you.
Thank you. Namaste.
Yeah, thank you.